Hello, my name is Mrs. Tench. Today we are going to be discussing Chapter 16, Depressive Disorders. So I'm going to go through the PowerPoints, and I'm recording this. Today is the 27th of August, so you've had 2 weeks of class starting. So I'm going to talk about some of the cases that we've seen in the hospital just to help you put a frame of reference for the disorders that we're going to be talking about. All right, so what is depression? This is just introduction. Depression is the oldest and one of the most frequently diagnosed psychiatric illness. Transient symptoms are normal, which means you can have sadness that comes and goes, and they're healthy responses to everyday life. So just to differentiate about sadness and depression. Okay, so this is foundational about depression. I want to make sure you understand people have adaptation things that they use to help with their moods. And when they become ineffective, that's when we start to see diagnosis of depression. So what is mood? It's called an affect. Okay, we talk about the conscious brain, the unconscious brain. Conscious brains are where your thoughts live, and your unconscious brain is where your moods live and your emotions and your response to things. So depression is an alteration in your mood. So sometimes we use these terms, and I want to make sure you have a clear understanding of what we're talking about. All right, common mood descriptions that you may be aware of: sadness, despair, pessimism. So how frequent is depression? During a person's lifetime, about 21% of women and 13% of men will become clinically depressed. There is a gender prevalence. Depression is more prevalent in women than in men, and it's about a 2-to-1 ratio. Age is a factor. Depression is more common in young women than in young men. The gender difference is less pronounced between the ages of 44 to 65, and then after the age of 65, women again are more likely to become depressed than men. Marital status also impacts depression diagnosis. Single and divorced people are more likely to experience depression than married people. And back to relationships and how important they are in our mental health. There's different types of major depression. Your textbook does a good job of differentiating. For this course, there's a lot of types, and the ones I'm going to focus on, of course, are the red and moving slides. So it's going to be major depressive disorder. I'm not going to spend a lot of time on dysthymic disorders. If you're interested in that, you can look at your textbook. Premenstrual dysphoric disorder, I'm not going to spend a lot of time on that. Substance-induced depression, I will spend some time on, and depressive disorders associated with other medical conditions. And when I've been in the and when I've been in the psych setting with you, I talk about the importance of ruling out medical issues. This really important with major depressive disorders, because there could be these symptomology that we see can be mimicked by endocrine problems, hormonal problems. So we need to have a good medical assessment of our patient, lab work, a good understanding of any co-occurring disorders that they may have, comorbidities. So we just don't jump to, oh, they're depressed. And I'll talk a little bit about that with you coming as we go through the slides. All right, so I told you we're going to talk about major depressive disorder, characteristic by depressed moods, loss of interest or pleasure in unusual activities, and that's something that we see with someone who is diagnosed with a major depressive disorder. All right, they're psychomotor, flowing, poor self-care. We see that in the psych setting. I talk a lot about that if you're with me in practicum, because if you're depressed and you're having high levels of anxiety, that they go hand in hand with your neurotransmitters. That's why people who are depressed have anxiety, and they they appear sluggish, but we talk about how your cognition is impaired. You have structural damage, organic changes in our brain. Our circuitry gets skewed from high levels of cortisol. Anxiety results in that. So our patients are exhausted. So just remember that when you're looking at their self-care. If you're helpless and hopeless, showering is not high on your priority list, and then you don't have the energy to follow through on tasks anyway. So just be considering that when we're taking care of our patients. And the symptoms have to be present for at least 2 weeks and no history of manic behavior. So manic is excitability behavior when patients have 2 moods, like it's on a spectrum. You could have like sad and euphoric, okay? We're just talking about sad. All right, there are mood disorders we're going to be talking about going forward in the next couple of weeks where you have a swinging of your moods, and that's not what we're talking about here. If your patient is depressed with is diagnosed with major depressive disorder, you wouldn't not have that diagnosis if you like go on these manic shopping sprees and like to run up your credit card. But there's something else going on. This is not the correct diagnosis for you. So just think about this as sad, all right? This is depressed. There's no elevated mood in with this diagnosis. And you cannot attribute this diagnosis to the use of substance or other medical conditions. So we have to, when we're doing our concept maps on the behavioral health unit, like look at the toxology report. Are our patients utilizing substance? It's very common in our society. Some people genetically have a more addictive brain, and they get they're exposed to a substance and then they're addicted. Others don't have that same genetic predisposition for addiction. Our brain tends to thrive on addictions. I mean, you can look at caffeine, you can look at chocolate, foods. There's a lot of different the response that our brain craves when we have these euphoric these endorphins that start to release, and then our brain's like, wow, this feels good, I like this. So they're going to repeat and crave things like nicotine or cocaine or whatever the substance may be. I got to rule that out, and medical conditions. So like I said, there's substance-induced depression and depression from other medical conditions. So what's the reason why people have depression? What causes it? Oh, we don't know. Many things about the brain we don't know. We know there's a genetic component. Heredity is very strong. That familiar predisposition and biochemical influences. They're genetically transposed. Deficiency in our norepinephrine, serotonin, and dopamine. That's an inherited chemistry, and then the circuitry becomes skewed from anxiety and stress, and some people are more vulnerable than others. So that's where you get this biological theories come into place, because we don't know what causes something. We develop theories on what we think causes them. So there's biological theories. There's excessive cholinergic transmission that can be a factor. Like I said, remember, there are some cortisol levels we can draw on our patients. We're starting to look at different diagnostic tools, labs that can help us diagnose these issues. But, we are not where we need to be as far as we have to do by clinical presentation. And that's why our assessments are so important. It could be a neuroendocrine disturbance. When we talk about our hypothalamic pituitary adrenal cortex axis, with our TSH, and that's why part of your concept map is to, what's your patient's TSH level, because skewed TSH, whether high or low, okay, your TSH, your pituitary is not happy that your gland, your thyroid gland is not making the metabolic needed hormones like T3, T4. So like the hypothalamus, pituitary, there's a loop and there's, wow, what's wrong with the pituitary? I mean, what's wrong with our thyroid? It's not working. Let's send more TSH, just thyroid stimulating hormones, to try to get that thyroid gland working. Well, that, um, in patients who have thyroid conditions, whether it be hypothyroid, hyperthyroid, thyroid cancer, nodules on the thyroid, all the TSH in the world isn't going to improve the function of that gland, but your feedback loop doesn't realize that. So we need to start looking at the function of the gland itself, and that's why you give like Synthroid, and you try to give medications to stimulate, to get the gland to work better, not just try to get the brain to make this thyroid work better. That's not going to help the issue. So that's why you have to rule these things out. And again, this is how this works. You learn this in A&S 1 and 2 or somewhere along the line. So that's the problem. And also, other medication side effects, neurological disorders, electrolyte imbalances, hormonal disturbances, nutritional deficits, other co-occurring disorders can all mimic depression. So we have to rule out medical before we jump to depression. And I have a family member who has Graves' disease, Hashimoto's thyroiditis. Okay, so she fluctuates between Graves' disease and hypothyroidism, hypo. She had her thyroid radiated and lots of negative consequences from that process. So, and she was feeling poorly. She was having anxiety. She was depressed. Her hair was falling out. She knows the symptomology, but she was so, her cognition was so impacted from her thyroid imbalance that she couldn't even realize that she was having severe hypothyroid disorder. In fact, she went into thyroid failure. Her TSH was 17. That's not even compatible. It means people at 17, they're in a coma. And she's like, I know this. Why did I not see the symptomology? Why did I have to go to the doctor? The doctor put her on a medication for depression, because she had an anxiety. She didn't know what was going on. So we put her on sertraline. So and then he called back and he said, well, your TSH is 17. You don't need an antidepressant. You just need to increase your armor thyroid. So that's why it's so important to know these levels. All right, so we've already said it's a biological factor. We're unclear what causes this. So the next thing, we're going to look at some psychological theories. We're going to look at what's Freud say about it. It's a psychosocial theory. He's on to something. There's a loss of your internal protection of your ego. There's also that learned behavior of helplessness and hopelessness, psychosocial theories of despair. We learn these behaviors. I'm a cognitive person. I believe that's what we think really impacts our mental health and well-being. So these are theories. So just to say, we don't know. So if you don't know what causes something, then you're going to develop some theories to try to identify what could possibly cause these things. So for this portion of our lecture, we talked about the prevalence of the disorder, what the disorder is. The next part of our learning time is going to be talking about the nursing assessment. So how do we assess our patient? So I'm going to stop this video and come back and start talking about the nursing process.